For healthcare providers and patients alike, the rise of ECG-enabled wearables has transformed heart monitoring from a clinic-only event into a pocket-sized habit. However, while these devices are FDA cleared for certain uses, they are not clinical grade in the way many users assume. Here is a breakdown of what separates your wrist from the hospital ward. The most fundamental difference is the perspective of the heart's electrical activity. When you touch the crown or button, the watch creates a circuit that mimics lead 1 of a clinical ECG. It looks at the heart from a single angle, typically across the chest from arm to arm. It is excellent for rhythm. Is the beat steady or chaotic? But poor for structure or blood flow of the heart. In a clinic, 10 electrodes are placed on the limbs and chest. This allows the machine to view the heart from 12 different electrical angles. This 3D view is necessary to see exactly where a problem is occurring. Example, the front versus the bottom of the heart. Misunderstanding the limitations of a smartwatch can lead to dangerous false reassurance. Atrial fibrillation. Yes, smartwatch ECG is FDA cleared for this. Clinical 12-lead ECG is still the gold standard. For a heart attack or blockages in blood vessels of the heart, smartwatch ECG is not enough, while clinical 12-lead ECG will detect either ST elevation in heart attack or show signs of ischemia. For valvular issues, neither smartwatch ECG nor 12-lead ECG is confirmatory. It requires an echocardiogram. For premature ventricular complexes or premature atrial complexes creating irregular beats, smartwatch ECG may be useful if it is caught during the 30-second recording. Clinical ECG also, it will be recording it much better. Please note that a smartwatch cannot detect a heart attack. If you have chest pain, a normal or sinus rhythm reading on your watch is irrelevant. You must seek emergency care. While modern smartwatches are remarkably accurate at identifying AFib or atrial fibrillation, an irregular rhythm from the upper chambers of the heart, often boasting 96 to 99% sensitivity in controlled studies, real-world factors frequently interfere. Up to 30% of watch readings can be labeled as inconclusive due to a heart rate that is too high, more than 120 beats per minute, or too low, less than 50 beats per minute, or simply because the user was moving too much. Shivering, talking, or even being near a plugged-in electronic device can create noise in the tracing that looks like an arrhythmia to an untrained eye. Here are the key takeaways for healthcare providers. Remind your patients that an irregular rhythm notification is a prompt for a checkup, not a diagnosis. Clarify the sensors. Distinguish between the green light, which is the PPG or photoplethysmography used for 24/7 heart rate, and the electrical sensor, that is the ECG, used for 30-second on-demand strips. For patients, use the PDF. Most watches allow you to export a PDF of your ECG. This is infinitely more useful to a cardiologist than a screenshot of the quote-unquote sinus rhythm result. The symptoms rule. If you feel heart palpitations, dizziness or shortness of breath, that is the time to take a 30-second recording. A snapshot taken when you feel fine is less likely to catch intermittent issues. As of early 2026, the medical community has shifted from skeptical observation to structured integration. Here are the current clinical rules of engagement for physicians and patients. The confirmation requirement. Guidelines now explicitly state that a smartwatch algorithm diagnosis like AFib detected is a screening result, not a clinical diagnosis. Manual review. Doctors are advised to never treat the watch's automated text output as fact. They must manually interpret the PDF rhythm strip provided by the patient. Then comes the gold standard confirmation. If the watch PDF suggests an arrhythmia, the standard protocol is still to confirm it with a clinical grade 12-lead ECG or a 24-hour Holter monitor before starting long-term treatments like anticoagulants or blood thinners. One of the biggest updates involves handling the 20 to 30% readings labeled as inconclusive. Algorithm limitations. Doctors are trained that inconclusive often occurs because the heart rate is outside the algorithm's range, typically less than 50 or more than 120 or 150 beats per minute, or because the rhythm is something other than AFib, like frequent premature beats. Clinical action. Guidelines suggest that if a patient has persistent inconclusive readings while symptomatic, the clinician should bypass the watch entirely and move to a medical grade patch monitor. A 2025 meta-analysis has quantified the gap that clinicians must account for. Algorithmic reading sensitivity 86%, specificity 94%. Manual physician reading of the watch PDF, sensitivity 96%, specificity 95%. The takeaway: the hardware is often better than the software. A trained cardiologist can often see a clear diagnosis on a strip that the watch's AI failed to categorize. Here are some recommendations. For stroke prevention, wearables are strongly recommended for opportunistic screening in patients over 65 or those with high risk factors like hypertension or diabetes. Post-ablation, that is after ablation, catheter ablation for atrial fibrillation. Doctors are increasingly using patient ECGs to monitor for AFib recurrence after a procedure, often reducing the need for frequent in-person visits. Data integration. New standards are being pushed to allow patients to push their ECG PDFs directly into electronic health records rather than showing a phone screen during a visit. Please note that patients should never change medication dosages based on a watch reading. A smartwatch can show a normal rhythm while the user is having an active myocardial infarction or heart attack, as mentioned earlier. No panic over artifacts. Sharp spikes or messy lines are usually electrical noise from muscle movement and not a dying heart. A note about the recently published EQUAL study, that is enhanced detection and prompt diagnosis of atrial fibrillation using Apple Watch, a randomized controlled trial. This randomized controlled trial concluded that 6-month smartwatch-based AF screening enhances the detection rate of new onset AF compared with standard care in patients at elevated stroke risk. That was published on 21st January 2026 in JACC Online.